Getting prepared, sir. Basavaraj, sir, just a minute. I think it will start.
Right. Good evening, everyone. Sir, can we start? Basavaraj, sir?
Yes, sir. Ready,
Yes,
sir.
yes. We'll start.
Yes. A warm welcome to everyone. Good evening. On behalf of Karnataka State Physiotherapy Federation, I welcome all to today's webinar. Today's moderator would be our good friend Dr. Manjunatha H, who's the professor and principal with East Point College of Physiotherapy, Bangalore. And today's speaker is again our very distinguished Dr. Basavaraj sir from Belagavi. He is a certified tutor, professor of Jeremy Lewis Shoulder Theory and Practical, assistant professor Department of Physiotherapy, BIMS, Belagavi, Bangalore, and founder Deesha Healthcare, Belagavi. Welcome, sir.
Thank you. Thank you.
Right. Thank you so much. It's going to be a very good topic that you've chosen to speak here, and I'm sure most of our viewers will be benefited. We are Facebook Live now, and it's streaming live. So best of luck, sir.
Thank you very much, Dr. Mahendra, sir.
Thank you.
Thank you, Mahendra. Thank you, Mahendra.
Good evening, one and all. Today, I am the moderator for my dear friend, Dr. Basavaraj S. Nanjannavar. So, I am very happy to introduce him. He has graduated at JN Medical College in 2000, and post graduation he has done in MS Ramaya in 2007, and he is certified manual therapist, and he is also a certified teacher for shoulder for both the practical and theory, and he was a resource person for many workshops, and he has also presented many papers, and presently he is working as an assistant professor at Belgavi Institute of Medical Science, Belgavi, and he is also one of the founder of Deesha Healthcare. So he is running the Deesha Healthcare in Belgavi himself, and today he will be presenting a sneak peek of rotator cuff related shoulder pain. I think it will be wonderful that so many new things you will be exploring and showing us. Thank you very much for being there with us today. Over to you, Dr. Basavaraj sir. To the viewers, kindly mute your audios until the session is over. 40 to 45 minutes, a resource person will be speaking, and later you can ask a question in the chat box, or you can raise your hand. We will allow you to speak. So I request everyone to mute your microphone. Thank you, everyone. Over to you, sir. Speaker, Dr. Basavaraj sir.
Yeah. Yes. Thank you. Thank you, Manjunatha sir, for giving us such a good introduction. And thanks to KSPF to give this platform to me to address all the distinguished viewers here. And today we're just trying to peek into what rotator cuff related shoulder pain is. And let's see, though this is a very common problem encountered by all the therapists, what's been happening around, let's just check it out. Well, the functions of the shoulder, as you all know, can be pulling, pushing, lifting, throwing, carrying, etc. And all these functions are being carried out by various joints and muscles around the shoulder joint, the shoulder complex. And because they are commonly used, shoulder pain seems to be one of the commonest complaint, and it is the second to fourth most common complaint encountered in the world, has a lifetime prevalence of around 70% with more than 65 years of age. Aged people experience 34% of them experience the shoulder pain, and has a resolution of around 21 to 50% in 6 months, but definitely can continue further on up to 1 to 3 years, which is seen in around 40% of patients. As you can see in this graph, the shoulder complaints are mostly seen in the 65 plus age groups here. Causes of shoulder pain are many, but among them we are much interested today in the rotator cuff causes. And let's see, apart from other musculoskeletal causes, you have visceral causes also, which can give about shoulder pain. So much of examination, during the examination and the assessment, one has to look around to come to a particular diagnosis. So rotator cuff related shoulder pain, it's a very in a generic term which has been given, which includes complaints like subacromial impingement syndrome, subacromial pain syndromes, and rotator cuff tendinopathies. So let's see, the rotator cuff muscles, as you can see in the picture, are the supraspinatus, infraspinatus, and the teres minor, which are on the left side, which are placed posteriorly to the shoulder joint, and the anterior placement is by the subscapularis, which is on the right hand side of the picture. So these form a confluence along with the coracohumeral ligament and the glenohumeral ligament, along with the joint capsule, and insert onto the humeral tuberosity. So it forms a cuff around the shoulder joint and mingles with the joint capsule and the ligaments, thus forming a very strong stability to the shoulder joint. The subscapularis, which is placed anteriorly, 60% of it is tendinous and 40% of it is muscular. And posteriorly to the shoulder joint, you have the supraspinatus, infraspinatus, and teres minors. The functions of the rotator cuffs include to bring about the rotations, basically, and you can see here the rotation, external rotation is brought about by the supraspinatus and infraspinatus, and the internal rotation is brought about by the upper subscapularis and the lower subscapularis. Now, it also helps in stabilizing the shoulder joint. Basically, as you can see in the graph here, the supraspinatus and infraspinatus are mostly active during the flexion of the glenohumeral joint, and they help in resisting the anterior glide of the humeral head. And while the subscapularis is mostly active during the extension of the shoulder joint and helps in resisting the posterior glide of the humeral head. We have also known from ages that supraspinatus initiates the abduction and all those things. But recent studies done by Reed et al. Here, the graph shows that apart from supraspinatus, various other muscles like the deltoid, the serratus anterior, the infraspinatus, and all are very much active during the initial stage of the abduction. So what we need to know is supraspinatus is not the only muscle which initiates the abduction, but there are other muscles also which are contributing to it. So the primary function of the rotator cuff is to center the glenoid head within the cavity. And this centering is brought about by force couples. Now we know about force couples which are acting on the scapula to bring about the scapulohumeral rhythm. We also have force couples in the glenohumeral joint. They are namely the coronal and transverse force couples. Now the coronal force couple is in the left hand side. It is brought about by the deltoid and the infraspinatus and teres minor placed posteriorly. So these help to center the head of the humerus in the glenoid cavity. And you also have a transverse force couple which is formed by the subscapularis and infraspinatus and teres minor anteriorly and posteriorly to center the head within the glenoid cavity. Now these this was the centering of the head. Now, but during overhead activities like about 90 degrees or at 90 degrees, and like for example when I'm throwing, now the rotator cuffs are very much active to bring about internal rotation or external rotation. So when these muscles which are acting at very high velocities in active throwing, and these muscles are active, now it may not be possible for them to act as a stabilizer of the humeral head also. Studies done in such a scenario have shown that all the fibers, the anterior build and the posterior fibers of their joint were active, such that along with creating an abduction movement, flexion movement, that employed was creating a force of the humeral head. When the contribution from axioscapular muscles, so the axioscapular muscles being the anterior, lower trapezius and upper midline upper trapezius. Now, this the motion has to move during activation. It has to keep moving so that the 90-degree angle formation between the humerus and the scapula needs to be bounded. If this is not maintained, then the deltoid will not be in the deltoid will not be in a position to they're asking me to tell about the role of deltoid again. Calculations about 90 degrees and about 90 degrees. Suppose some others overhead athlete who is throwing a ball.
So there's some voice issues. Could you please correct?
Hello. Hello.
So your voice is breaking, sir. Manjunatha, sir, are you able to hear me properly?
Now it's coming, sir. Now I can hear.
I think Basavaraj sir
Dr.
had some
Mahendra, I can
issues.
hear you.
Yeah, I think Dr. Basavaraj had some
Okay,
issues.
maybe.
He'll rejoin. Yeah.
Okay. Thank you, sir. Thank you. Basavaraj, sir, you have to unmute. Okay. No, your voice is echoing, sir.
Still not audible, sir.
Not clear.
Sir, can you off the video, sir?
Dr. Mahendra,
Yes, sir.
you may be having a dual audio, both the mobile and the laptop. You can ask him
Yeah.
to mute one and unmute another so that overlapping will not be there.
Yes, sir. I'll do that.
Yeah, thank you.
Vinod. Yes, yes.
Your voice is clear, sir. Now.
ಇದು ಮುಂದೆನೆ Yes, I'm sorry for the delay which happened because of some technical reasons here. So where we are just looking into the functions of the rotator cuff muscles, and we just saw how what they do, that is they bring about internal rotation and external rotation. And while they're busy doing internal rotation and external rotation at overhead activities, that is at around 90 degrees and above, the deltoid becomes active there because when they are active, the centering force being brought about by the rotator cuff muscles will not be fully accomplished. So studies have shown that deltoid was more active at 90 degrees and above, and bringing about a compressive force on the head of the humerus, holding it into the glenoid cavity, and it is helped by the axioscapular muscles, that is the serratus anterior, lower trapezius, upper trapezius, and middle trapezius. There's a lack of consensus about the etiology of the rotator cuff related shoulder pain. And well, there are a lot of intrinsic causes which relate to the tendon health, genetics, age, vascularity, the type of loading that happens, frequency of the loading that happens, and all those intrinsic factors can cause rotator cuff related shoulder pain. Extrinsic causes, that is contact with the surrounding structures, which can they can be definitely be a cause for the pain. And like for example, the rotator cuff tendons may rub over the humeral head when it is translating superiorly, or it may go and hit the coracoacromial arch above the rotator cuff tendons, and the subacromia, the acromion also may come and rub against the rotator cuffs and all those things, and muscle fatigue, delayed activation of the muscles around the scapula or the rotator cuffs, which bring about instability, and postural deviations like forward head postures, and all those things are extrinsic causes. And lifestyle factors like metabolic syndrome, smoking, and all those things can also be a factor for causes of rotator cuff pain. And so we all know that impingement is one of the most important cause, as we have studied, and it is the impingement is being caused by the overlying acromion. But studies have shown that majority of studies have shown that the most of the rotator cuff tears that have happened are on the underside of the tendon and not on the superior side of the tendon, that is towards the acromion. So this negates the fact that acromion may be a causative factor in creating a rotator cuff tear. Also, for a when a acromion is the when a subacromial space is causing the pain, they do a subacromial decompression. Now, when the subacromial decompression cases were compared with structured and supervised exercise program cases, they didn't have more important clinical effect when compared to each other. So this says that structured superior exercise programs can definitely be equal to a subacromial decompression cases. And also we have the studies have shown that even after an arthroplasty, in an impingement syndrome, rotator cuff tears do happen even after an arthroplasty. So all these things say that impingement may not be by the the tears may not be caused by an acromia. The other cause for rotator cuff related shoulder pain may be excessive tissue loading or maladaptive loading can be a principal cause of tendinopathies. The scapular dyskinesis can be a cause, and the kinetic chain disruption can also be a cause in the pain, shoulder related pain. And as you can see for scapular dyskinesis, in the picture you see that the normal scapular movement is happening, which is brought about by the force couples around the scapular joint, brought about by the serratus anterior, upper trapezius, middle trapezius, and lower trapezius. Now, this is a normal movement for a scapula, which is happening during the arm elevation. So, in an arm elevation, the scapula should upwardly rotate, posteriorly tilt, and externally rotate. Okay, but in a scapular dyskinesis, it has been seen that there's less of upward rotation, less of posterior tilting, and greater internal rotation, which is happening, which can lead to subacromial space reduction, causing a compressive force on the rotator cuff tendons. Also, with shoulder pain cases, abnormal muscle recruitment patterns have been seen in shoulder pain. It has been shown that serratus anterior and lower trapezius muscle activity have decreased, and the upper trapezius muscle activity has increased. Now, this muscle activity changes leads to change in the force couples, leading to altered movements of the scapula. So that's how this scapular dyskinesis. So in majority of the shoulder cases, with rotator cuff, around 68% to 100% of patients experience alteration in the scapular motion. So that was about scapular dyskinesis. Coming on to the kinetic chain, we all know that in a throwing athlete or a throwing, office worker or a house worker who uses, throwing movements, their forces need to be generated for the shoulder to have work efficiently. The forces need to be generated right from the bottom, through the foot, through the knees, hip joint, lumbopelvis, the trunk, and through the scapula into the shoulder. So when the forces are created from the bottom into the shoulder, the work done by the shoulder muscles will be less. So as you can see here, initially the force creation starts from the legs, the trunk, shoulder, elbow, and the wrist. That's how in a throwing movement happen. So the energy from the proximal segment is transferred to the distal, and there's a progressive increase in velocity from the proximal to the distal one. if there is any problem within the kinetic chain at any joint, say the hip joint or the trunk flexion is not good, or the abductors are not hip abductors are not working properly, or the pelvic tilt is not proper, etc., then what happens, the subsequent segments, that is the upper trunk or the scapula, when that segment is not working properly, they absorb energy, decreasing transfer to the distal segments, and there's increased work by the distal segments now. So if the transfer of forces from the trunk through the scapula to the shoulder is less, then what happens? So one has to create load of force at the shoulder muscles. Now this increases the load on the distal joints, such as leading to shoulder muscle injuries. So those were the causes for for the rotator cuff related pain. And assessment definitely of shoulder complex has a reputation of being difficult to examine because of a lot of multiple articulations, multi-layer envelope of soft tissue structures. There are around 17 muscles and attached to the scapula, axilla humeral, scapula humeral, and all those cases, all those muscles. And the examination, we have over reliance on imaging with on MRIs for any shoulder related problems, but MRIs are also not up to mark now. Studies have shown that up to 34% of painless shoulders demonstrate a rotator cuff tear on an MRI, though it is not there, but still they show an tear. Now, so you just cannot say that that rotator cuff, can be responsible for the pain. Special tests also have been proven to be less accurate. Now, these empty can tests or the open can tests, which are for rotator cuff muscle like supraspinatus, they are designed to isolate a muscle and test it, isn't it? So they should actually test that muscle only. And it has been designed like that, and we have all followed it and studied it in that way. But recent studies have shown that through EMG studies, that special tests for the rotator cuff muscles, I'm speaking of rotator cuff muscles, not instability tests and all those. So these tests have shown that only the supraspinatus or the infraspinatus or the scap are not involved, but other muscles also get involved. Like in an empty can test, 8 to 9 muscles are active during that point of time. So it may not be the supraspinatus which is bringing about the pain. It can be any other muscles because so many muscles are involved into it. So a structural differentiation just cannot happen through special tests or MRIs. A thorough history should be taken while you assess the case, and a pain diagram or analog pain scale should be used to find out the perception of the amount of pain so that the behavior of the patient can be understood. And using a VAS and all those things you can determine the irritability of the condition on which you can base the further testing. For the athletes, overhead athletes, you ask questions like in which stage of caulking or the follow through does he have the pain, so that you can find where the problem is in that kinetic chain and which muscles are affected can be understood by that. And you also ask him, has there been any change in form of technique that he has done recently, or change in training frequency, duration or intensity, or change in the partner, change in the playing partner, in fact. So all these can put changing loads, varying loads on the shoulder muscles, rotator cuff muscles, so which can bring about a tendinopathy kind of issues. And observation definitely has to be done in assessment, and observation has to be done in standing positions with the arm at rest by the sides, and also with the hands on hips position with the thumbs pointing posteriorly. So look for forward head posture, bruising, discolorations, and other things. Look for the scapular muscles, whether they are atrophied or abnormally bulky, or there's any swelling. Look for scapular orientation, whether it's internally rotated or translated above or protracted or retracted. All the things have to be seen. And also in the assessment, range of motion assessment is also very important. And in the range of motion, when we speak, internal rotation and external rotation are very important. And GERD, glenohumeral internal rotation deficit, has been of a very in a lot of use these days. And GERD is glenohumeral internal rotation deficit. So if a loss of, and it is compared with the normal side, when compared with the normal side, if there's a loss of around 20 degrees or more, then it is said to be positive. Now, but no, in overhead athletes who do pitching or throwing or tennis players, GERD, is always positive in them. Now that is because of the muscles, internal rotator muscles, that they use more of it, or because of the addition of more of humeral torsion in such kind of players. GERD, is normally there. So for excluding such cases, the other cases can be considered as positive. Now, apart from GIRD, TROM, the total range of motion, that is the addition, you add up the internal rotation and external rotation both, okay, and compare it to the other normal side. If the when compared, if TROM is more than the difference between the two, if it is more than 5 degrees, then it is positive. Okay. So when these both are put together, a pathologic GERD occurs when the shoulder has GERD and a concomitant loss of TROM more than 5 degrees. Okay. So the GERD also has to be there and the TROM has to be more than 5 degrees. So during, apart from range of motion, you test for the strength also. Strength in presence of pain cannot be, you cannot measure it appropriately. And also in presence of, change in posture, poor posture also can cause, cannot give appropriate strength measures. Evaluate the scapulohumeral rhythm. During arm elevation, protraction has to happen, and during arm depression, retraction has to happen. Now, if this does not happen, then the scapulohumeral rhythm will be altered, and scapular dyskinesis will be the reason for it. And Kibler has defined different type of scapular dyskinesis. The type 1 is the prominence of the inferior angle. Type 2 is the prominence of the inferior and the medial border. And type 3 is the prominence of the medial border and the superior border of the scapula. You can see in the first figure here is the type 1. This the third figure is the type 2. And the center figure, you can see there's a shrugging movement associated with arm elevation. This is a type 3 kind of Kibler scapular dyskinesis. To assess scapular dyskinesis, you do various tests. Lateral scapular slide test are done, scapular assistance test, and scapular retraction tests are done. Many orthopedic tests and imaging may use them to support the clinical examination rather than depending on the orthopedic special tests. Also, during assessment, you can use, because now as we see in, the structural diagnosis is definitely difficult to make in a shoulder, okay, because of all these imaging problems and special investigation, special test problems and all those things. So what do we rely then on now? So the reliance can be, now what are the things that we see? That is the symptoms like the pain, the movement and all, quality of movement and all the range of movement, all can be the symptoms. Now you can make use of such symptoms, create activities which change the symptoms. Okay, now such activities can be used as tests. Okay, so recently, lately, such a procedure has been utilized by Lewis, Jamie Lewis, and it is called as shoulder symptom modification procedure. It makes use of symptom modifiers which inform about clinical management. Now, in this one, different thoracic postures are used. Now, I say when we it can be thoracic flexion or thoracic extension. Now, first, what you need to do here, you need to find a provocative movement. Like, for example, my arm flexion is the cause of pain. Now, what I do is in this procedure, there are various positions which have to be taken, for assessment. So first is a thoracic position. Now I put the person in a thoracic flexion kind of posture and then do the arm elevation. Now if the pain of that person reduces, during with the thoracic flexion, then that position of thorax has to be utilized in further management program. So likewise, you have various scapular positions where the scapula can be retracted, protracted, translated upward, downward, posteriorly tilted, etc. Humeral head positions, superiorly translated, inferiorly translated, anteriorly translated, posteriorly translated. So you maintain these head positions and ask the person to do the aggravating movement. If the symptom reduces, then use that position in the treatment program. What happened?
Continue, sir.
Yes, sir. So SSMP techniques found to reduce symptoms are then used to treat the symptoms. If the first three stages, that is the thoracic, the scapular and the humeral head stages, do not reduce the symptoms, then the final stage of SSMP assesses symptoms through manual therapy procedures in cervical, thoracic and shoulder regions. Well, it is out of the purview of, it definitely takes a lot of time to explain SSMP. I just given a gist of it here. So SSMP helps us to choose the safe exercises in the initial stage. It is a safe entry point. Now we are doing only those movements which do not cause us pain while doing that activity. We choose that activity. Okay. So it helps us to choose safe exercises, safe activities in the initial stage, based on which a set of exercise program can be built upon. Okay. So this is a form of SSMP which can be used. Okay. Well, from the assessment we move on to the management, and the clinician and the patient now have to solve the problem. So the clinician should understand and acknowledge the impact of the problem which has happened to the patient. Now that is to have an empathy. He has to provide information related to the cause, prognosis and expected outcome to the patient. He needs to provide pain education, okay, because a lot of constant pain, night pains, or persistent pain are always there with the patients. He should avoid instilling fear component within the patient, saying, your acromion is pinching onto the rotator cuffs, or it may not improve, you need to undergo surgery for this, and all those create a fear component in the patients. And he has to empower the patient in believing, yes, we will work it out and make it improve. which can lead to changes in behavior of the patient, his attitude and knowledge and commitment towards the problem. So when the patient is empowered, then I think everything should change. So this, you should make the patient responsible for the improvement of the condition rather than you being responsible for the improvement of the condition. And you should also provide opportunity to the patients to discuss understanding the condition. You have to properly understand him the condition. He will have recovery expectations, and the treatments that they consider to be effective has to be understood properly. And treatment what the clinician provides has to be understood properly. There are different management techniques. So depending on the, we all just saw that load, altered load can lead to tendinopathy issues. So my load management techniques can have to be understood here to put on what kind of exercises, how they have to be put, and all those things have to be understood. And we have seen scapular dyskinesis. So how do we manage a scapular dyskinesis along with kinetic chain corrections, if at all, if it is there. So when load as a key contributor to the development of tendinopathy, a reactive tendon must get a reduction in load to have time to adapt. Okay, so always when you start with the rehab process, start with a low load so that the tendon has time to adapt to this. If you start applying higher loads initially, then yes, there will be problems within the tendon wherein protein synthesis or collagen synthesis can be affected in the tendinopathy issues. So putting more load to a tendon at an early stage could theoretically make the tendon worse. In later stages, that is, tendinopathy has 3 stages. The initial stage, at the reactive stage, it is called as the disrepair stage, and the degenerative stage. In the second and third stages, the focus of treatment should be graduated tendon loading. The first stage and second stage to some extent are reversible condition, whereas the third stage, the degenerative tendinopathies are quite irreversible in nature. So, and degenerative kind of tendons usually lead to partial and full thickness tears. So when some points to be remembered during loading, significant cuff tendon compression is observed in adducted shoulder positions. Internal rotation whilst the arm by the side position is associated with 3-fold increase in subacromial pressure. External loading is accompanied by relative reduction in subacromial pressure. Loading the shoulder in adducted position is likely to increase compression on the supraspinal stem. So we all have seen, and we have been doing, all these days, the exercises with arm by the side, give him a TheraBand, keep with the arm by the side, just do these activities, isn't it? So when you do these activities, then see what happens. So if arm not by the side, then where to start the loading? Is it? So supine lying with 90-degree flexion or side lying with 90 degrees abduction seems to be an appropriate position, where there's a high degree of control over the load being borne by the rotator cuff, and the cuff is in synergy with the deltoid here, than in isolated fashion that occurs in traditional arm by the side external rotations. From there, how do you progress the loading? You use long levers with addition of resistance tubing between the foot and the hand. Now this resistance tubing mimics the standing posture, wherein the tube acts as a gravitational force. Load can be objectively progressed over time, increasing the long lever demand on the cuff and the deltoid. In summary, the load can be manipulated in 2 ways: increasing dumbbell load along move from short lever to long levers, okay, and provide graduated exposure to tensile to the loads, increase tubing resistance, and how often and how many repetitions do these exercises have to be done when you put these loads from low loads to higher loads, simple activities to complex activities. Based on research studies of changes within tendons following loading, commence with low load, externally paced slow cycle, and with exercises aimed at producing fatigue. Initially commence with low volume of repetitions to ensure tolerance. Load selection is how much of load has to be selected is based on the dynamometry, or you can make selections based on 1 RM or 5 RM or 10 RMs depending on the ability of the person in that condition. Several sets of 8 to 15 repetitions initially performed daily is gradual, generally well tolerated. Essentially, load progression is implemented through volume before increases in weight. So change the volume before increase the volume until fatigue before increases in weight. Ultimately, the cuff needs to be meaningfully loaded within tolerance to achieve desired improvements in capacity. Several research activities, all these activities, research activities have shown that it takes around 12 weeks for a shoulder condition to improve. And as such, one should use a graduated loading over 12 weeks time frame to achieve desired tendon adaptation. This is also like a fracture, wherein you give time to heal and then you slowly rehab it. So tendon is also similar to a fracture wherein you have to give time for it to get back to normal. And if there is any scapular dyskinesis, you check for the inflexibility. Inflexibility can be in the thoracic spine, the pectoralis minor, the posterior shoulder complex, the posterior capsule, the infraspinatus, rotator, teres minor, upper trapezius, levator scapulae, latissimus dorsi. All these have to be checked for inflexibility, and if it is there, address it so that flexibility is achieved and more effective exercises can be put on. If scapular dyskinesis is there, then it can lead to lack of scapular retraction, lack of scapular protraction, too much of protraction. That is the control, the control over the scapula is lost in this, because of scapular dyskinesis. So you should effectively manage it. And how do you do that is you should always, when you start managing scapular dyskinesis, rehabilitation should always start at the base of the kinetic chain, right from the foot or the trunk or the hip or the pelvis. Just check whether is there any strength deficiency or the balance is not proper in the trunk, whether there's a core issue. If at all any of these are there, address them. So in the earliest rehabilitation phases, hip and trunk motions are the foundation necessary to achieve appropriate scapular motion. Then you integrate it with these movements with the scapular movements. Begin with isometric and then start off with where you integrate through the closed chain exercises. These lower hip and trunk are integrated through the closed chain exercises. Closed chain exercises improve scapular motor patterns and allow for healing of the tendons. As scapular control increases, progress by decreasing emphasis on the proximal facilitations. And as proximal control, once you get a control of your proximal you integrate scapula with the shoulder now. Okay, so start using from closed chain exercises, move to open chain exercises. Okay, the type of exercises that are used are weight shifting exercises for closed chain, weight shifting exercises initially, rhythmic ball stabilization exercises, scapular clock exercises, wall slides can be utilized again in closed chain, the low row exercises, the push-up plus exercise, all closed chain exercises. As the athlete's scapular neuromuscular control improves, open chain exercises may be initiated. Adding open chain exercises increases the endurance capacity of the selected muscles and they can be performed incorporating the entire kinetic chain. Increased difficulty when you are using the open kinetic chain exercises, increase difficulty in the closed kinetic exercises through by the use of various Swiss balls or the wobble boards or the Bosu ball, etc. So make use of them. Open chain exercises, for example, the shoulder dump exercise is done in this way. This helps in improving through the kinetic chain, improving the retraction of the scapula. Other open chain exercises are, the dynamic hug, the prone row, the prone shoulder extension, horizontal abduction in neutral or in external rotation, and the dynamic hug. The dynamic hug or a bear hug, what is called as, improves the activity of the serratus anterior. You have shoulder punches, shoulder punch, which is, that also can be utilized. In the prone overhead arm raise, you can use for middle and lower trapezius exercises, improvement of the lower and middle trapezius strength. Further on, all these open chain exercises have to be integrated with lower components. Okay, you make use of stance raise, make use of lunges, make use of trunk rotations, and all those things. Integrate them with the lower extremity and the middle part, and improve the motor control in that, for that shoulder. So that was about scapular dyskinesis and the kinetic chain exercises that we use for in the treatment process. Now we saw SSMP, shoulder symptom modification procedure. There we saw that during assessment the battery of tests from the SSMP when applied will bring forth activity which is less proactive. This activity is used as an entry point in an exercise program, and from here you design a structured graduated exercise programs. Okay, this is also, apart from assessment, one of the best treatment designing procedure. And the potential mechanisms by which SSMP may reduce symptoms include changes in position of the scapula, changes in the length tension relationship, change in the subacromial space, change in the position of the humeral head, and neuromodulation of pain. So this is how, in just, it was a sneak peek, but I think it became a bit more. So, well, thank you for giving an opportunity, and thanks for the patience listening, and sorry for the delay which happened in between.
Thank you very much.
Thank you, sir. Thank you, Manjunatha, sir. Anything further on? Hello, sir.
Basavaraj sir, thank you very much.
Okay, sir. Okay. Thank you, sir. Thank you.
Yeah, it was wonderful listening to you.
Yes, sir. Yes.
We regret the inconvenience it happened. It's okay, the technical issues.
Yes,
But
yes.
yeah, there was a wonderful flow in your presentation. So I am very happy. And we will make the listeners to ask questions. So
Yes, sir.
people who can ask, they will raise hand. So kindly we'll check into, sir. So
Yes, sir.
participants, anybody has a questions, you can raise your hands and you can speak directly to our Dr. Basavaraj sir, and you can clear your questions. Meanwhile, while the listeners raise the question, sir, I have one doubt. You said that during the causes, the arthroplasty can also become a cause for the shoulder rotator cuff injury. How to
No,
tackle
no.
this? Because most of the time, what we see, any rotator cuff injury comes, the surgeons or even orthopedician will go for a surgery. They will not advise for physiotherapy.
Correct,
So,
correct.
which is the stage that physiotherapists will take a direct access to this, and where they start the treatment?
So any condition of a shoulder can be anything, be it a labral tear or a rotator cuff tear, anything. You can take it into the rehabilitation process. Okay, I'm talking about through SSMP. You can take it into an rehabilitation process and start the rehab process from a where the pain is non-existing. You find out an
Okay.
activity which is not creating any pain
Okay.
and start working from there, from the scratch into the this thing, and increase the load or strength or of it. So with this one, there will be definitely be a change in behavior of the patient, and also the condition improves.
Fine, fine. There is one question from our listener, sir. Uh, is winging of scapula is considered in Kibler's test, which you have demonstrated the Kibler's
Hmm,
test?
hmm, hmm, hmm. What does he ask? Is winging of
Is,
scapula?
yeah, is considered.
Yeah, that is what, if there's a, medial, medial winging, inferior angle is lifted out, or the medial part which has come out, they're all winging only, which is happening there.
Okay, okay, okay. I think you also shown the picture in the diagram
Yes,
also.
yes,
Yeah, yeah,
yes.
yeah. Thank you very much. There is anybody asking the questions? Anybody raising the hands, Dr. Mahendra, sir? Okay, so there is one question, sir.
Okay.
From our listener, can you brief about the clinical predictor of rotator cuff tear, especially in the supraspinatus tear where there is a 12 o'clock or 3 o'clock position
Uh,
with the lateral movement?
uh.
Can you brief the clinical predictor for the supraspinatus tear, rotator cuff tear? And also they continue asking, another one is conservative management is good or the surgical management is good? If we are going for conservative management, can we when we start them to do the active sports activities?
When do we start with the active
Sports
sports?
participation in the sports.
Okay. So now I have briefed about everything.
Yeah,
How do you make a safe entry point in any condition, be it whatever case it is, isn't it? You have to find a safe entry point for that shoulder. Make use of that activity which is not provoking any pain. Increase loading gradually. Move from short levers to long levers. Move from you know change the volumes until the fatigue, change the frequency, and
yeah,
all
yeah.
those things. Keep adding them slowly, one by one. There is no protocol as such for anything. You have to decide how do you go about with it. If it is highly reactive, use ice packs and then go on with the, or you need to wait until it if it is highly irritable, the exercise programs will be at a very low level. Isometrics have to be initiated initially if it is highly irritable, and once the irritability reduces, then you start more, including more of exercises in such a, whatever the way I told you.
Okay, okay, okay. Thank you very much, sir.
Okay, okay, sir.
There is one person who wanted to speak.
Hmm.
Hello.
Hello.
Hello. Hello.
Hello. Hello.
Hello. Am I audible?
Please tell.
Good evening, sir.
Good evening. Good evening. Please tell me.
So it was a nice session. Thank you. Thank you for it.
Thank you. Thank you.
But I would like to ask you a question. You said that most of the clinical tests which you do, they somehow like may not be actually accurate. And then when you do those MRIs, like 34% of them, like even in non-symptomatic shoulders, might be showing a tear. So when do you finally decide like which cases can be taken up for like physiotherapy and which cases should be given up to a orthopedician for a like repair or sort of thing?
If any shoulder case comes to me, I will not leave anything. I'll take it for me.
Yeah.
Okay. And structural differentiation definitely cannot be done here.
Yes, sir.
Okay, because of so many reasons. First of all, imaging has not answered our questions accurately,
Yes, sir.
and it has to only substantiate. It has to help support your clinical
Test.
examination.
Yes.
All these, whether they are special tests or imaging, they have to support your clinical examination rather than you basing your decision on them.
Yes, sir. True.
Okay. And
So what is trying to say is, as you have already mentioned, even the MRI also not very sure that accuracy is giving. In
correct.
which after what are the symptoms, you will grade them to whether you can start the treatment or you need a surgery. So decision point.
Yeah, decision making. So that's what I want.
Yeah,
Sir,
yeah. That's what
sending
you want.
before sending any case to a surgery,
Yeah,
unless
yeah.
and until it is an unstable shoulder, instability is okay. Okay,
Correct.
because
Correct. Yes, go on.
apart from them, only the rotator cuff related shoulder pain I'm speaking of,
Okay, sir.
you can take any case into your control. Start,
Okay.
enter, and safety, a safe entry point has to be checked, has to be searched for. It will be there. Safe entry point will be there for any given condition. Okay, and that has to be checked, that has to be searched, and from there you start. You just can't put a person coming with a shoulder pain and just start off with flexion or abduction exercises. You just can't do that. You have to search for some entry point wherein the pain is 100% less, which is not at all there, and then you start working from there. Okay, so
Okay.
what happens here is when you do this, apart from creating a movement in the shoulder, you are empowering that patient. The patient is now understanding that such a movement can happen in my shoulder. So this is a biopsychosocial kind of approach where you are making him believe that something can happen, and from here, once you start moving in this direction, definitely you will get a good result.
So, further asking you, sir. So, like, suppose the patient has come with me. He's got a like drop arm test positive. His MRI shows that it's a complete tear, and like he's unable to lift it up at all. So, in
Mm.
that case, what do I do? Like, do you still consider it like you should go in for physiotherapy?
Yes, yes, yes. Please, please. You start off with physiotherapy in this case also. Nothing, you have to, but you have to be at the initial stage. Now it may be a highly irritable case, isn't it? So, depending on the examination, you have to base your management. So you can definitely. It is not that if it is a total tear of a rotator cuff, um, it has to undergo surgery. No, definitely not. You can have improvements in that case also, but provided you have patience and the patient has a patience, and you move steadily, into the exercise regimen.
I think you're right, sir. As you mentioned already, SSMP will be a key guide where you can decide what is the stage and how you can modify the technique and all. It's wonderful.
Yes,
I
sir.
think
Yes, sir.
I think
SSMP is a wonderful guide for us.
it's not mandatory that all the person with the instability or severe pain will go to the surgeon. So it is better to assess by ourselves as an independent entity. Maybe when it is over crossing, then you will definitely know with the procedure. I think you can refer to the opinion of a surgeon maybe later. I think
Yes,
it's
yes.
right. Right.
But you have to move very steadily. You just can't. If any case comes of such, highly irritable case or a partial tears or full thickness tears, the decision making is very important. Okay. Please do not. When I have said that you can take the case, it is not like that. You have to examine it thoroughly, then make a proper clinical decision as to how you are going about to manage it. Okay. So to start from zero, then
Thank you very much.
simple to complex, it has to be moved.
Yeah. Thank you very much, sir. So there was one question coming from Dr. Kripa Singh, I think. Kripa Singh, are you there? You can come in. If you raise your hand, so you will come online, you can ask questions. Kripa Singh, are you there? Okay, I think she's not there.
Yes.
Anybody want to ask a question, our speaker? So raise your hand. We will put on video and audio mode so that you can ask directly our speaker.
Hello.
Yeah. Yes.
Go on.
Doctor, it's me, Rimsha Afridi from Pakistan. I want to ask a question that how can we differentiate between a adhesive capsulitis and a rotator cuff syndrome, while the symptoms are quite similar?
Yeah. In the early frozen shoulder, they seem to be similar.
Good question. Yeah,
Yes,
go ahead, sir.
yes.
Thank you.
Well, if it's usually in early frozen shoulder, it's highly, it may be very irritable also, isn't it? And you have to base your, understanding on the clinical findings and check for a wide variety of, try to find the answers and in if the usually in early frozen shoulders there will be a bit of muscle guarding associated, so not in this thing, the rotator cuff this thing. So you have to check for them, and the time is this thing answer for it, mainly when you want to differentiate between frozen shoulder, early frozen shoulder, and rotator cuff injuries.
I think you're right, sir. But what we can do is, because we have to differentiate where you're testing, whether you're testing in the joint or outside the joint. The rotator cuffs, which are actually at the binding force around to keep the glenoid force inside. So hence here you can differentiate by doing glide movements or maybe with the muscle test again. MMT will also play a role here to differentiate whether you are having a pain in the joint or an outside the joint, the binding forces which are acting around it.
Yes. And also many of these frozen shoulder, we also get confused a lot. These frozen, with a lot of shoulder stiffness, I want to say, rather than a frozen shoulder. These shoulder stiffness cases, which may make a frozen shoulder, isn't, they are actually muscle guarding rather than a capsular,
Right.
tightness.
You're right.
So you have to, check out, try to work on it through SSMP. Again, wonderfully, what we thought as frozen shoulders in our clinical practice have worked wonders by the use of SSMP. Again, a biopsychosocial is an answer for it rather than going structurally again. So we all need to move from a biomedical point of view to a biopsychosocial point of view. A lot of considerations have to be taken, and definitely an answer will be got when we take such a stance.
Thank you, sir. Thank you very much. Any more
Thank you.
questions, viewers? I think this, Dr. Rimza, your question is answered.
Yes, thank you so much, sir.
Yeah. Okay,
Thank
welcome.
you. Thank you.
Apart from that, anybody else can ask your questions, raise your hands, you will be put on video or audio mode.
Hello, sir.
Yes,
Yes,
madam.
madam, come in.
Hello, sir. My question is, what are the contraindications for rotator cuff? If there is some rotator cuff tear, what are the contraindication in treatment?
Madam, your good name, madam?
Smita Kadu.
Okay, okay. Thank you very much. Sir, you can go on, sir.
Yes. Contraindications to treatment. I said irritability will be the contraindication. You need to find, severity, irritability, and the nature of condition. So if the severity is high enough, if the irritability is high enough, well, yes, definitely they will be contraindicated. You have to look around for, many other pathologies, sinister pathologies. Check for them. They may be be a contraindications. Check for any other red flags, associated red flags around. If there is any vascular issue, if there's any, so those also will be contraindicated in this one. So apart from this, I don't think many contraindications are there. You can take them when you move them safely, when you move safely into the rehab program.
Okay.
Okay, sir. Okay, sir. But they said overhead abduction is many times it is a contraindication. So is it like that?
Day
Or?
one, I just mentioned in my talk again, day one, you just cannot take them to overhead abduction. You have to do it slowly. You need to have patients move from simple to complex.
I think rather it is a contraindication. I think you need to take a precaution during these activities, because when you're doing a overhead activity, you're putting a lot of a load.
Correct.
So that you have to take a precaution how to increase. So you can gradually increase the force on the muscle group so that you can get into that.
Use short levers instead of long levers.
Yes, exactly.
Okay.
So it's not that you have to avoid. So you should proceed with the graded level. That's right. Yes.
Okay. Isometrics and all we can start first.
Yeah.
Initially we can start.
Short or movement, you can start with the different stages. You can do it.
Okay.
And once you feel that you are confident enough, then you can go to the further range. And then again you can increase the resistance also accordingly.
Okay, sure.
But
Sir.
if you're giving an advice, or if you're giving an home care or advice to the clients, so better to avoid initial stages, so overhead activities, so that let them do in front of you, in front of a therapist, and maybe later you can give them those exercises. That will be better.
Yes.
Okay, and sir, what about passive? If we ask them to do with the other hand, should we go for it or not? Passive overhead abduction or flexion.
Yeah. Until and unless it is supported. When it is supported, the loading will definitely be less.
Okay, sir.
I think the passive movement, when they're doing, there should be a thorough passive movement should be there, because once you lift your hand from the other hand, like how you are doing with the supportive movement, when suddenly the weight distribution varies in a different range, this may get hurt more. So if you are just doing a passive movement, I think it will not cause much problem. Definitely.
Again, now when you hold a hand and then lift it up, then it's not good. I had in my talk I had told, with internal rotation, when you do abduction, there are a lot of loads being put on the shoulder, rotator cuff muscles. So that needs to be avoided. You have to think out of the box how you are going to do it. There is no set protocol. You have to understand the principles before then you know, take a step forward.
Yeah. It is a gradual increasing the load and the range accordingly. Correct, sir. Thank you.
Yes.
Are you clear, madam? Anybody else has a questions from the listeners?
Hello.
Hello.
Yeah.
Nimish speaking from Pune.
Yes, please tell me.
You're not audible. Can you speak little louder?
I wanted sir to elaborate on the scapular test that he mentioned, like LSST and SAT, etc.
Okay. Well, see here, this was a very small session. Okay. I just cannot elaborate on each and every test. You know, just mention them. You know, scapular slide test. You know, I just can't point you where to keep the. You know, find us nearest spinous process to the scapula. Okay, and then I'll explain in one test. Okay, scapular slide test. Okay, with the, you know, you have to do it in arm by the side of the body and at 90 degrees and at elevated this thing, and this thing, you know, find a spinous process which is nearer to the inferior angle of the scapula or any point that you want to measure on the scapula, then measure that distance, and now take the shoulder to 90 degrees of abduction or elevation, then measure the scapular, the distance from that very spinous process to the you know, to the angle, to the point on the scapula which you had measured earlier. If there is any difference, check for the difference between the two. If the difference is more than 1.5 centimeters, you know, 1 to 1.5 centimeters, then the test seems to be positive. Okay, so that is how you have scapular assistance test and scapular retraction test. In scapular assistance test, you assist the scapula in, you know, the scapular behavior is upward rotation, okay, with posterior tilting and external rotation. So you assist the scapula with your hand. If there is pain in elevation, do to find out whether it's dyskinetic, assess that scapula in upwardly rotate and posteriorly tilt. If the symptoms disappear, then the test is positive and it is a scapular dyskinesis is present. Like that, you know, you have scapular assist, you know, retraction test.
Thank you, sir.
Thank you, sir. Any more questions from the participants?
Hello. Hello.
Yes.
Yes,
Go on.
yes.
Yeah, my name is Pankaj. I just want to ask that whether there is any neuropathic component in shoulder examination which we can rule out.
What component?
Neuropathic pain component. Apart from, yeah, apart from nociceptive pain, because most of the time when we are talking, it's some nociceptive fibers which are affected. But is there any neuropathic component we can rule out while doing shoulder examination?
Neuropathy in the sense neural involvement, you are saying?
Maybe somehow, yeah. Like in back pain, most of the time we get some of the, like there is nociceptive component and there is no neuropathic component. So in shoulder pain, is there any condition where we can rule out that this pain may be due to some actual nerve damage rather than that of the component that we are talking about?
See if there is any the supply of nerve to the serratus anterior or the supraspinatus, etc. like this. If they are, you know, affected, you know, then those palsy will be there, and you can see the winging happening because of serratus anterior, the nerve to this thing which is affected. So winging will be in a scene. So accordingly, that has to be managed in that way. Now that
I think neuropathic component will not come here, sir, much, I feel.
Okay.
Well, if it is a reference from the cervical component, yes, can be there. C5, C6, C4, C5, C6 afflictions, if they are there, yes, you have to answer that. Okay.
Okay. Thank you, sir. Thank you. Thank you, sir. Very nice presentation.
Okay, thank you very much. Thank you, everybody. Thank you, all the listeners. Dr. Mahendra. Thank you very much, Dr. Basavaraj, sir.
Yes, sir. Thank you, Manjunatha, sir. Thank you so
Wonderful
much.
listening to you. Wonderful being with you.
Yes,
I'm
sir. Yes,
very
sir.
happy
Same
that you have put a very nice effort to get us a good presentation, and
Yes,
also all our queries been addressed. Thank you
Yes.
very much.
Thank you, sir.
And I take this opportunity to thank all the participants who have participated from Bangalore and outside Bangalore and all over Karnataka and even all over India and around the globe. So, being listeners, thank you very much. Thank you one and all for participating. And we'll be continuing another webinar that the list will be given. It will be announced shortly. And your presentation was so good, sir. And let us speak to Dr. Mahendran, sir. Dr. Mahendran, sir, is joining now. Maybe a minute.
Yeah, thank you, everyone. It was a wonderful talk by Dr. Basavaraj.
Thank you, Dr. Mahendra.
Glad that we have you on the panel and you're always forthcoming to do such topics. Thank you very much, sir, for taking your time and enlightening us about the rotator cuff injuries. Thank you, Dr. Manjunath. Sir, you always stepped up to times when we need you. Thank you so much, and it's a great insight. I hope
Thank you very
all the
much, sir.
participants are benefited out of it.
Yes.
Thank you, Karnataka State Physiotherapy Federation.
Yes.
KSPF. I thank personally from my side and from Dr. Basavaraj side and for all the listener side that you people have put an effort to make this successful. Thank you very much. Thank you one and all from
Thank you.
KSPF and all the listener. Thank you.
Thank you, KSPF.
One more.
Tell me.
One more announcement here. We would be having series of webinars now from now on. Tomorrow, Dr. Vinod Babuke would be presenting the topic. We will be releasing the topic shortly, and we will intimate you through the
Thank you
WhatsApp.
very much.
I would request everyone to please